Hello everyone, and welcome to CMNCP22, the annual conference of the Canadian Municipal Network on Crime Prevention. My name is Katie, and I work for CMNCP. And before we begin, I'd first like to acknowledge that I am joining you from Kitchener, Ontario, which is the traditional territory of the Haudenosaunee, Anishinabek, and Neutral peoples. And on behalf of CMNCP, would like to thank you all for joining us during this year's conference and for this session on ACEs, or Adverse Childhood Experiences. This session will be moderated by Lee-Ann Chevrette, and we will also have presentations from our panel, which is made up of Kimberly Granholm, John Dixon, Dawne Clark, and Chris Mushquash. And just a heads up, because we want to make sure that each panelist has enough time for their presentations and that we have time for some questions at the end. We won't be reading the full bio of each of the panelists, but we do have all of that information in our conference handout or our website, so please feel free to refer to that for additional information. So without further ado, I would like to hand it over to our moderator for this session, Lee-Ann Chevrette. So Lee-Ann has extensive experience working in forest ecology, wildlife biology, and environmental education for governments, Indigenous organizations, and not-for-profits. And so Lee-Ann is currently employed as the Community Safety and Wellbeing Specialist with the City of Thunder Bay. So thank you so much, Lee-Ann, for agreeing to moderate this session. And I will now hand it over to you to set the stage for our panel conversation and introduce the first presenter.
Thanks very much. Can you just confirm that you can hear me, Katie?
Yes, and we can also see you, Lee-Ann, too.
So I want to first acknowledge that I'm joining you from Thunder Bay, Thunder Bay, Ontario, which is built on the traditional lands of the Anishinabek Ojibwe people of Fort William First Nation. And they are signatory to the Robinson-Superior Treaty of 1850. And I also want to acknowledge that it is Treaty Recognition Week in Ontario and acknowledge that we are all treaty people. So I'm delighted to be here. Welcome, everyone. Glad to have you with us. And I'm really pleased to be moderating this session on prevention, mitigation, and intervention of adverse childhood experiences. The project was developed as a result of longstanding conversations between staff with the City of Thunder Bay and the Thunder Bay District Health Unit, and our combined interest in deepening our community's understanding of the impacts of adverse childhood experiences and trauma on the developing brain, and the lifelong mental health and physical health implications that can result. So we believe that a deeper understanding of this is really necessary to create prevention and intervention strategies in our community, and that this information will be beneficial to all communities committed to improving safety, well-being, and health. And we also believe it's really important for developing more compassionate and resilient communities. So between 2019 and 2021, I had the privilege to be among 50 individuals from across the country who came together to participate in a national 2-year program called Brain Builders Lab. And that was coordinated through the Canadian Centre on Substance Use and Addiction. And the program really built on Brain Story, and which includes a free online certification program. And I encourage anyone who hasn't seen this and hasn't taken part, please look into that. And the program aimed to move the science of brain development into policy and practice. So I'm super grateful to have had that opportunity. For me, it really did provide an additional lens through which I could view the work that I'm doing in community and some of the challenges related to health and safety and well-being that I'm committed to improving. So I'm going to just explain the process and the structure of this particular panel. So over the next 90 minutes, the presenters will provide an overview of the project results, and we'll discuss the impacts of ACEs, the historical and structural challenges that can exacerbate ACEs, key approaches to prevent them, and potential solutions to improve conceptual models related to ACEs. So again, the session is 90 minutes. Each presenter will have 12 minutes to speak, which will be followed by a Q&A. To ensure that each panelist has enough time for their presentation, we'll hold questions until the end. If you think of a question or have for a particular panelist, please type it in the chat. We will be monitoring the chat for the Q&A at the end. So I ask you all to avoid any background noises. Just keep your microphones muted during the presentations. Okay. So without further ado, I'm going to introduce Kimberly Granholm, our first speaker. So Kimberly is a Lakehead University graduate. She has a Bachelor of Science degree in nursing and a Master's of Public Health with a specialization in nursing. She has been practicing as a registered nurse since 2012. During her master's degree, she collaborated with us on this project at the Thunder Bay District Health Unit, the City of Thunder Bay, and the Canadian Municipal Network on Crime Prevention to conduct a national scan of adverse childhood experiences, prevention, and intervention approaches. So I'll turn it over to Kim and invite her to share her presentation with us.
Hello, I'm Kimberly. Thank you, Lee-Ann, for moderating this session, and thank you all for taking the time to learn more about ACEs and the work that's happening within our communities. This session marks the official launch of a project report that I was a part of on adverse childhood experiences. Recognizing the significant impacts that ACEs have on health, safety, and well-being, we developed an online survey to gather information on ACEs-related programs and interventions being implemented in Canada. Today, I'll provide a brief overview of the results. This project was created in collaboration with Rosemary Scoffich from the Thunder Bay District Health Unit, Lee-Ann Chevrette from Community Safety and Wellbeing Thunder Bay, Audrey Monette and Katie Cook from the Canadian Municipal Network on Crime Prevention. Utilizing knowledge and expertise from multiple organizations helped us to create a well-rounded scan and reach multiple sectors to find information on the many programs and interventions that are currently implemented in Canada. The report we created is based on the contributions of individuals and organizations that participated in the survey, in addition to a literature review, which provided background information on ACEs. I would like to acknowledge that the programs and interventions highlighted have been implemented on the traditional territories of the First Nation, Inuit, and Métis peoples from coast to coast. We wish to honor the Indigenous people who have lived here and cared for these lands for thousands of years. Adverse childhood experiences became a topic of research in the 1990s from a study published by Fility et al. The original study included a set of 10 ACEs, as listed on the left-hand side of the screen, which focused on experiences of childhood physical, sexual, and emotional abuse, physical and emotional neglect, and various childhood experiences of household dysfunction. Given that the concept has evolved over the last 25 years, for our survey, we collectively decided to expand upon this list in order to encompass aspects of inequality, violence, and trauma that are experienced by many Canadians. Our expanded list of ACEs included the experiences of intergenerational trauma, racialized trauma, community violence, intersectionality with gender, and the impacts of COVID-19. The purpose of this project was to hear from organizations across Canada about their experience with implementing evidence-based and promising approaches surrounding the prevention and mitigation of ACEs. We aim to identify programs and interventions implemented in communities, which may lead to creating a more comprehensive picture of ACEs programs across Canada. This can aid in the design and development of ACEs prevention and mitigation activities, promote the importance of ACEs prevention and mitigation to policymakers, identify opportunities for future funding and development and potential gaps in ACEs initiatives, and advance the conversation on the connection between ACEs and community and safety well-being efforts. Along with the project's purpose of identifying programs and interventions surrounding ACEs, it was hoped this information will also identify and highlight promising practices used within Canada and create partnerships to address ACEs within our communities. So there were a total of 49 surveys completed, outlining 41 programs addressing ACEs in Canada. Survey respondents represented organizations from Ontario, Alberta, Manitoba, and Saskatchewan, describing their community settings as urban, large cities, small cities to towns, suburban, and Indigenous communities. Program information was shared from a variety of sectors, with the greatest number of programs provided by social services, not-for-profit organizations, municipal government, and public health. There are many protective factors that mitigate or prevent ACEs at the individual, family, and community levels. Our survey asked participants which protective factors for ACEs that are supported in their community. The top 10 protective factors identified were access to mental health services, safe, engaging after-school programs and activities, access to substance misuse services, school-based health promotion education, initiatives that foster infant and child and caregiver attachment, opportunities for youth to participate in sports, access to economic and financial help, nurturing and safe childcare, initiatives to increase community cohesion, and anti-racism initiatives. This feedback helps to identify areas of strength that our communities are upholding. There are individual, family, and community risk factors that increase the likelihood of someone experiencing ACEs. When asked which risk factors for ACEs apply to participants' communities, the top 10 risk factors identified were domestic violence, poverty, accessibility to drugs and alcohol, discrimination based on race or ethnicity, substance misuse, intergenerational trauma, homelessness, the impacts of COVID-19, lack of access to counseling services, and a lack of awareness about the impacts of ACEs. This feedback helps to identify areas of need for policymakers and program developers, which may aid in the creation of programs and interventions addressing these issues. The bulk of our report outlines specific information on programs and interventions that reduce, prevent, and mitigate ACEs. The chart on the screen outlines the target audience or population of these programs as reported by participants. A breakdown of each program identified during the scan is available to view in the official report. Information provided about each program includes an explanation of the program goals, their target population, location and organization who runs it, the sector, community setting, level of prevention it addresses, the ACEs addressed by their program, and some additional links to their websites. Additional information was collected in the survey surrounding enablers, needs, barriers, and constraints that organizations experience when working on ACEs. We asked participants what has best enabled your ACEs prevention and mitigation work. The most common enablers identified by survey respondents was dedicated, skilled personnel to drive this work, access to high-quality training, and program promotion and awareness. We also asked participants, what do you need more of to enable your ACEs prevention and mitigation work? The most common needs identified from survey respondents were appropriate funding, access to high-quality training, and monitoring and evaluation resources and supports. This feedback can be considered when implementing or reevaluating programs addressing ACEs. An impactful outcome from this survey was the creation of a set of recommendations for current and future ACEs initiatives. They're a combination of suggestions from the survey findings, literature review, best practices, and from the project contributors. 32% of survey respondents identified that they knew a little about ACEs. Therefore, increased service provider education and training is recommended. A similar recommendation is increased community awareness and education on ACEs. Informing individuals and communities about ACEs, risk factors, health and behavioral impacts, and the intersection of ACEs can play a proactive role in prevention. As I stated earlier, the concept of ACEs has evolved since the original study in 1998. Therefore, we recommend an expansion on the current list of ACEs in order to capture current and emerging ACEs experienced by Canadians. Based on the survey data, participants identified the most important area that could feasibly be addressed to make the greatest impact is to strengthen supports for infants and children. It's recommended to advocate for education, programs, and policies that support infants and children. Acknowledging the large Indigenous population within Canada, the First Nations principles of ownership, control, access, and possession are important to include when doing future research on ACEs and evaluation of ACEs programs in Canada. It's important to include these principles to ensure proper interpretation and communication of Indigenous information, ensure no unintended harm is being caused, avoid stigmatization, and ensure the outputs of the work are not perpetuating stereotypes. Other recommendations include to advocate for funding to strengthen impact of ACEs enablers, advocate for evaluation of ACEs initiatives in Canada, develop an inventory of ACEs resources, establish and explore existing ACEs communities of practice, advocate for inclusion of trauma-informed approaches in policies and programs, improve service provider awareness of levels of prevention, address gaps in ACEs intervention, and improve reach for future ACEs scans. Further explanations and guidance on these recommendations are outlined within the report. These recommendations can be taken into consideration when developing and implementing interventions to prevent and mitigate the impact of ACEs. Thank you again for taking the time to learn more about ACEs and the prevention, mitigation, and intervention approaches. You can find further information on this official report, which is now available for you to view.
Thank you very much, Kim. Well, that's just in time for me. I finally got my computer working at home. So thanks everyone for your patience with me in that regard as well. Thanks again, Kim. I'd like to introduce our next presenter, John Dixon. So John Dixon is currently the Director of Integrated Services at Dilico Anishinabek Family Care in Thunder Bay, Ontario. He is a member of the Mississaugas of the Credit First Nation and has been working in various frontline and management roles in the addictions, child welfare, and social services fields since 1997. Welcome, John. I'm glad you're here with us today, and I'll turn it over to you for your presentation.
Good afternoon, everybody. Thank you, Lee-Ann, for the introduction. As mentioned, I am from Treaty 13 in Toronto, where some of you are sitting watching today. Delivering my presentation here from the traditional territory of Fort William First Nation, part of the Robinson Superior Treaty area. I don't have slides. I am not really a slide presenting kind of guy, but I thank Kimberly for putting those slides up. They triggered some nice things in my mind to remind me to speak about. So for that, I'm very thankful. The additional ACEs are something that's really important to me as an Indigenous person. Adding those expanded ACEs recognizes some of the historical trauma that Indigenous people in this country have experienced. And if you look at some of the health discrepancies we have, you know, there's numerous reports that have been put out from the federal and provincial governments over the last number of years that highlight how we are doing much more poorly in terms of our health outcomes, our educational outcomes, our incarceration rates. One can look at a lot of these reports in silos and kind of, you know, say these are, you know, terrible things, and they're, you know, maybe getting into kind of discussions about stereotypes and things like that. But if we put all these reports together, what they do is they almost highlight our history, and the outcomes that we have right now speak to the adverse childhood experiences that a lot of our people endured in the residential schools as part of the 60s scoop. And even prior to that, within families in the residential schools. And it's important to me to have that those extra ACEs because they're identifying and articulating a problem that we as Canadians face and we have to deal with. You know, reconciliation is partly about doing some of that work to go backwards and to look at some of those historical things that are causing the discrepancies that we have in this day and age. And I think it's important when we're talking about advocating in terms of ACEs to keep those things in mind when we're speaking with government partners, regardless of the organization we represent, because we all service Indigenous people somewhere within the system, within the various sectors that we come from. And I think if we can't articulate ourselves around these issues, we're not doing justice to the needs of the people that we're servicing. You know, the Indigenous population has a lot of needs that are very distinct from mainstream Canada, from regular kind of in-city people that have grown up. You know, it's a different kind of impact when it's a systemic impact that's happening to people. And I think that's the piece that's important to me, is to make sure that we don't create systems or structures that continue to create systems that allow for systemic racism or you know, imposing programs or services on people without speaking to them about their needs and their wants and their desires. These are the things that, if we're going to undo history, we need to change our approach. If we want to have children growing up without these types of adverse childhood experiences, we need to have a different discussion. And I think we're at a point in time where we're at a point in history where we can have those kinds of discussions differently. And I find it promising in my region. You know, Lee-Ann actually lives up around where we do, you know, and it's nice to see that municipal level governments are starting to have those discussions now. 10, 15 years ago, those discussions weren't happening. So it's really nice to see that, you know, that advocacy and this awareness around these types of things are creating connections in different spaces than might have been before, because it's a problem we all have to work on together. I think another thing with addressing adverse childhood experiences is a resourcing question right now, particularly when we speak about caregiver substance abuse problems. You know, and in my system, I can work with maybe 250 people a year in an area that has a really hugely identified opioid misuse concern. So we have higher levels of people with a lot of adverse childhood experiences. I worked in a treatment center for a number of years before I got into this position that I'm in now. And part of my job at that time was around the residential school claimants process that happened, identifying some of that trauma that people went through. And part of that was reading through file histories to determine the number of types of abuse and things that people had happen. And this was before I was really aware of ACEs, but, you know, looking back in hindsight, you know, a lot of the population there had a minimum of 4 to 5 ACEs. So it's a population that's, you know, deeply, deeply impacted. And I found the complexity presented in that population to be considerable, to need extra resources, to not be responsive to the kind of typical old ways of dealing with addictions through non-evidence informed approaches or less culturally sound approaches to dealing with addictions. And I think culture is a key point in ACEs. We need to give people their identity, particularly children, to be proud of who they are, their identity, their culture, their ethnic history. All of that needs to be instilled in kids to be proud of, you know. And I can see a difference in the education system a little bit. It's starting to progress. I have children. They're in the school system now, and they learn about a lot more things in that regard than I ever did when I went to school. So we are moving forward as a society. They're small incremental moves, but they're moves forward nonetheless. And I think the only way to ever close a disparity in terms of the outcomes between our two populations is for us to start having these conversations, to start kind of breaking down the barriers between, you know, the different levels of government, the different levels of people funding things, to get them all around this type of a concept, to understand and have a model of understanding for the things that we need to be tackling from an evidence-informed perspective. You know, if we don't use what we know already, too, that's another failure on our part. We know a lot. We've done a lot of research on trauma-informed approaches, and it's important to make sure that we're integrating those kind of evidence-informed pieces, and where Indigenous people are involved, to make sure that we're balancing that appropriately with cultural services and connections to elders and their identity and ceremony, because those are the things that can help people kind of heal from that historical injustice. I think one of the big things going back to the treatment center piece is we had really good outcomes, and it's mentioned in the service summary there around bringing culture back into treatment. And I can't stress that enough. You know, when we're talking about undoing and reconciling our history, part of our history was about, you know, denying the identity of an Indigenous person. making sure that we don't exist going into the future. And I think that's coupled with a lot of the other problems we see in the reserve communities where there's been no investment in infrastructure. And I think as a people, we were meant to not be here. So the government really didn't have much of an incentive back in the 60s and 70s to further invest in building houses and those sorts of things, because reserves weren't meant to be the long-term thing. We were supposed to be absorbed into the broader Canadian politic, and we haven't. So I think if you look at that, lack of investment at the community level in the microcosm of a First Nations community, you can see how ACEs compound upon one another. When you can't escape the poverty, you can't escape the lack of clean drinking water, you can't escape the over-representation of incarcerated people returning to your community and having to live in your house as a family member, because you have nowhere else for them to live. If they don't live there, they go to the homeless kind of piece, and that's not a good outcome for our people either. So I think the big thing that I'm trying to say is, at the community level, without investments, it's going to be hard to undo adverse childhood experiences. It's hard when you live in a place with no heat, no water, with 15 other people in a space that's designed for about 4. When your modeling in your home is the substance abuse, and you can't escape that, and you don't have those good role models, those are the things that, it's really hard to be preventative. But ACEs aren't prescriptive, and we are resilient people. We're resilient enough to survive 500 years of trying to make us not be here anymore. So I think that acknowledgement of how strong we are as a people is another thing our kids need to know. We're strong, we can heal, we can do better, and we will do better. And I think, in closing, because I don't want to speak too long, because I know Dr. Mushquash has a lot of wonderful things to say, as does our other presenter there at the end. So I just want to say thank you for allowing me to speak today. And I think, our path forward is together, across this province, working hand in hand, understanding the issues, and making sure that we're doing our best to make sure that we don't replicate situations that have been into the future.
Miigwech, John, thank you so much for being here. I just want to say John is a member of the advisory committee for community safety and well-being Thunder Bay, and I've had the great pleasure of working with him over the last several years. So thanks again for your wise words there, John. So our next presenter is Dr. Dawne Clark. And I'm pleased to introduce Dr. Clark. I've had the opportunity to work with her a few times over the last several years as well. Dr. Clark is Professor Emerita in the Department of Child Studies and Social Work at Mount Royal University in Calgary, teaching and researching in the early childhood field for almost 50 years. That is quite an accomplishment. Over the years, Dawne has researched, educated, and worked to impact policy in areas such as early childhood, the adolescent brain development, active play and physical literacy, and children's mental health and resilience. Thank you so much for being with us today, Dr. Clark, and I'll turn it over to you for your presentation.
Thank you very much, Lee-Ann, and thank you, John, for setting your context, and for Kim to be reviewing this study. So I would like to say that I am speaking to you from about an hour northwest of Calgary, which is the traditional lands of Treaty 7 and the Métis Region 3 in Alberta. So I'm going to present a very different perspective in that I have also been involved for years with the brain building journey that Lee-Ann talked about at the beginning, the brain story, and have been involved in the ACEs from the date of publication virtually. So I'm going to talk a little bit about the journey to understand ACEs. If we could have the next slide, please, Katie. So the original ACE study was something that was intended to try to provide evidence on a large population health perspective, epidemiological study, could provide evidence to say that things that happened in early childhood may affect a person 20, 30, 40 years later in terms of their mental, physical health. And this study was one that actually turned everything that we understood about childhood and about childhood resilience on its head. This study showed us that children are not as resilient as we still in this society today tend to believe. I do a lot of work with the Alberta Coalition of Women's Shelters here in Alberta. And there's still the belief that young children, if they don't see domestic violence in the home, they're not aware that it happens. They believe that children are too young to remember, that they'll forget, or that they're so resilient they'll bounce back. And this ACE study turned that understanding on its head and made us really careful to explore what happens to our young children. How do we address that? The study was done in San Diego with Anda and Felitti in partnership with the Centers for Disease Control. They had over 17,000 participants. So these were patients who came into Kaiser Permanente with a health complaint. They were generally middle-aged, around 50, in their 50 years old. They were middle class because they could afford health insurance. They were primarily Caucasian. We're going to come back to what those three mean in terms of the ACEs as we see them now. The other thing I want to say that we're going to come back to is that approximately 60% of the participants in this study, about 67 actually, reported experiencing at least one ACE before the age of 18. Next slide, please. So Kim has already talked about the 10 adverse childhood experiences that were studied. And I just want to comment here that these particular ones were not chosen because they were believed to be the only ones or the more serious ones or ones worthy of study. They were chosen because in a large population health study, you need to choose items which are discrete, easily identifiable, and people can say, yes, I experienced that. No, I didn't. So patients, when they came into Kaiser Permanente with a health concern, were asked if they would complete a very simple study, their survey of 10 questions. So each of these were listed. They could answer yes or no. It didn't matter if they only experienced something once or if it was chronic. It was still just a yes. And then the ACEs were totaled. And what that allowed the researchers to do then was to look at the accumulation of ACEs and the health complaints that patients, 34, were now bringing to the hospital. What did they find? Next slide, please. So let's start at the bottom, the two pieces at the bottom, because I think in our society, we're fairly confident that we understand if somebody has a rough childhood, they're going to experience some depression or some kind of mental illness during their life. I don't think what we understood yet was that ACEs are cumulative. The more ACEs you have, the more likely it is that you're going to experience these challenges. And so if we look at the chart to the right, we can see that the approximate 33% of Americans with no ACEs would experience 1 in 69 being alcoholic, 1 in 480 using IV, and 1 in 96 attempting suicide. But if you move to the far right of that chart, where we're looking at the 16% of the population with between 4 and 8 ACEs, now we have 1 in 6 are alcoholic, 1 in 30 use IV drugs, and 1 in 5 attempt suicide. So the accumulation of ACEs creates more probability of negative outcomes. The one that really stuck me in the top left-hand corner being in the field of early childhood, we know now that the first 5 years of a child's life are the most important years for building the structure, the architecture of the brain. And that structure is built in those early years through responsive relationships and positive experiences. When children are experiencing instead adverse childhood experiences in those early years, they don't have positive relationships and good experiences, and the brain literally suffers. It isn't a healthy, strong brain. And this really impacted me, this chart, that if a 3-year-old has experienced 7 ACEs or more, they are virtually guaranteed experiencing neurocognitive delays. Think about what that means for a child. We'll come back to that in a minute. What I didn't understand and what I needed to work around in my own head was the impact of ACEs on physical health. And so working within the brain builders and within those concepts, understanding that experiences that children have, they don't forget them. They don't just bounce back. They may not be able to remember them or articulate them, but those experiences have been built into the developing brain and into the developing body to the point where 20, 30, 40 years later, those children will be experiencing significant cognitive delays and also physical challenges. Next slide, please, Katie. To try and explain this mechanism, the two researchers, Anda and Felipe, put together this ACE pyramid to see how one thing builds upon and leads to another. So starting with the adverse childhood experiences, if that happens in either the very early years when the brain structure is actually being developed, or later in adolescence when the brain is being restructured and it becomes a very sensitive time for youth, that results in disrupted neurodevelopment. If the brain is not developing properly, that can lead, not will lead, but can lead to social, emotional, and impairment. So think about that. If you have impairments in the areas of social and emotional development or in cognitive development, it's very difficult for you to be successful in school. It's difficult for you to create lifelong, sustained, healthy relationships, to find a good job and to stay in that job. And without those things in your life, you become less successful at life in general. And that often leads to the adoption of risky behaviors, such as self-medication using alcohol or drugs, or sexual promiscuity for teenagers. Those risky behaviors can lead to disease, disability, and social problems. And that's where the strain on our social systems, the strain on understanding from society in general, all of those things begin to happen. And through those things, these people experience early death. So it's almost an inevitable pyramid leading to the early death. Next slide, please, Katie. So why middle class? Why middle-aged? Well, it was incredibly important to use that population because it showed that ACEs affect every layer of our society. There was no way anybody could use the ACE study and say, oh, well, that just affects them. It doesn't affect us. No, with this particular population, it demonstrated that ACEs affect all of us, affect all of our children, and therefore ACEs are all our problem. It does, of course, suggest that vulnerable populations may be disproportionately affected, but that the effects of ACEs are apparent well into the life trajectory. Now, we've heard about the expansion of the original 10 ACEs. And I'll just say again, the original 10 ACEs were not chosen because they were considered to be the most important or the ones that would have the most effect. It was just something that they were identifiable and easily recognizable. This particular infographic from PACES Connection shows how easy it is to expand the ACEs. And all of these in this particular infographic are the result of research that's been done in this particular area. So they start with the household, number one, and those are essentially the same 10 that the study used. There's a couple added in there, such as bullying. It's the community that really makes an impact. And I think this is where John was speaking, because at the community level, here's where we're talking about intergenerational trauma, chronic poverty, systemic racism, poor schools, poor education, low-paying, substandard housing, lack of clean water. All of those things rest in the community level. And now increasingly, they're looking at things that happen more at the environment level. When I was growing up, our biggest concern was the Cold War. Now it's the climate crisis and all of the things that we've been witnessing over the last few years in terms of floods and droughts, and the natural disasters with hurricanes and tsunamis. And notice that they've added the pandemic I think we're going to find a lot of concerns around what has happened with the isolation during COVID. Next slide, please, Katie. Going back to Harvard's Center on the Developing Child, where the brain story was developed, they're very strongly saying every time you talk about ACEs that they are not our destiny. They haven't written the future of our life that we cannot change. And there are 3 principles that they have proposed to improve outcomes for children and families is to support responsive relationships. If children have around them people who care for them and love them and support them no matter what, they have better results. Reduce the sources of stress. Notice that they don't talk specifically about ACEs, but sources of stress. What are the things that are stressing that family, that are stressing that child? How do we reduce those sources of stress for that family? And finally, how do we look at all the adults who are around the children, not only their family, their early childhood educators, their teachers, their coaches, their neighbors, their bus drivers? How do we help everyone in the child's sphere to strengthen their core life skills, to enable them to have nurturing relationships and sustain long-term relationships, to be successful in school and at work? How do we help the adults who are supporting the children strengthen their core life skills? And the final slide, Katie, please. So with references there, very short and quick, and I would say thank you very much.
Thank you so much, Dr. Clark. It is always just such a pleasure to hear you speak about this topic. I really appreciate that. So next I'm going to introduce our final speaker, and that's Dr. Christopher Mushquash. So Dr. Mushquash is a Canada Research Chair in Indigenous Mental Health and Addiction, and professor in the Department of Psychology at Lakehead University and in the Division of Human Sciences at the Northern Ontario School of Medicine. In addition to his academic appointments, Dr. Mushquash is a registered clinical psychologist providing assessment, intervention, and consultation services for First Nations children, adolescents, and adults at Dilico, Anishinabek Family Care. So I'll turn it over to you. Welcome. Thanks for being here.
Thanks so much, Lee-Ann. And thanks to all of you who are out there in this Zoom meeting listening in today. Thanks as well to Katie for her very, very capable assistance and setup of all this. And of course to Kim and John and Dr. Clark for really providing fantastic overviews of very, very complex issues. So, I think one of the things that I've noticed in terms of when people are first exposed to information associated with ACEs or the ACEs studies is that, there is this sort of general tendency to take a bit of a hopeless perhaps stance or a bit of a deterministic stance, and as we've seen from Dr. Clark and certainly heard from John and Kim as well. There are a lot of reasons to feel as though it's certainly a very, very difficult situation, but there's also a lot of reasons to be hopeful. And sometimes the way that we think about a problem or a question determines the way in which we carry on interacting with that. So if we look at it in a hopeless kind of way or deterministic kind of way or a fatalistic kind of way, then we feel that way about it. But if we can understand it in a bit of a different way, then perhaps we can be more optimistic or hopeful, or even utilize what we do know to provide a framework for understanding things in a way that allows us to do something different. So, we heard about the nature of dose-response relationships from Dr. Clark, that the idea that 2 ACEs incurs more risk than 1, and 3 incurs more risk than 2, and 4 incurs more risk than 3. And that's true. And that's an important thing for us to know. But another important thing for us to know is that dose-response relationships are bidirectional. And what do I mean by that? Well, what I mean is that 3 ACEs incurs less risk than 4, and 2 is less risk than 3, and 1 is less risk than 2. And there's a lot of things that we can do in terms of the preventative space with respect to ensuring that kids aren't exposed to things. In fact, we do this in our communities already. Anytime a family member steps in when somebody's having difficulties with mental health or substance use in the home, I mean, these are preventing ACEs And, we don't often think about it in that way. We kind of think about it as our responsibility to our families and communities, but not necessarily in a way that is helping us conceptualize it as being a way of reducing risk of a whole range of different mental health, addiction, and broader health outcomes. So that's one thing I notice. The other thing I notice is that people, sometimes tend to try and make individual level predictions based upon this population level data. And that's something that we can't do. Population level data is very, very good at predicting things at the population level, but it's not particularly good at predicting things at the individual level. Although on average, when you take an individual out of a population, they're more likely to, so suppose that person has a high number of ACEs, they're more likely to have other health related concerns. It's not always the case. And in fact, you may know people or have worked with people, or maybe even yourself, have experienced adversity, but yet have been able to, through some way, still manage to do okay. Let's say, for example, increased risk of smoking and smoking related cancers. But if you never smoke, then your risk of smoking related cancers is the same as anybody else who doesn't smoke, regardless of how many ACEs you have, right? So there's a lot of thinking that I think we in conversation we need to have around individual level prediction versus population level prediction, and knowing what it is that we're talking about when we're doing this, and not necessarily trying to apply ACEs population data to ourselves or to individuals, because it's really not meant to understand things like that. But there is a lot to understand at the individual level. So the research shows that there's quite significant impacts of ACEs on brain development, and we can further and further specify what those are. Dr. Clark gave a very, very good overview of some of those mechanisms, right from stress response, to prefrontal cortical development. So what I mean by that is, attachment, the process of biological attachment that we have, that 0 to 5 window is very, very important for how our brain develops. And in particular, as we get older, how that front part of our brain behind our eyes develops. And that's an important part of our brain. That's where a whole host of sort of functions called the executive functions exist. And executive functions are things like your ability to control impulses, your ability to manage your emotions, your ability to plan, your ability to sort of keep an eye on yourself and adapt yourself accordingly. So, any situations that require complex kind of decision making, or difficult decisions in novel environments and experiences, those are areas that are implicated when it comes to disruptions here as a consequence of ACEs. The challenge is that there's a lot of things that could potentially go into the bucket. We saw a very, very comprehensive overview of that. You could in our communities define what those are, rigidly, or you could kind of take a broader look at it. And there's a lot of different ways to do that. Potential solutions as well. There are a lot of evidence-based ACE prevention and treatment where ACEs have occurred. So, we have heard of resilience. We have heard that people can overcome a lot. In an ideal situation, just because people can overcome a lot, doesn't necessarily mean we ought to be giving people things that they have to overcome. So, if we can orient our thinking toward the prevention of ACEs, I think that there's a lot of benefit downstream from that. And the work that we do in municipalities, all of the different portfolios that are touched upon, within a municipal structure, could be conceptualized as being part of the picture when it comes to preventing adversity in children. I think one of the ways to improve the way that we think about ACEs and the way that we think about our systems of service and our different portfolios and our buckets and our mandates and all of those types of things is to understand the life journey in a more connected way. Typically we have these discrete developmental windows that align with portfolios or mandates or whatever it is, and funding pockets and jurisdiction and everything else. But the reality, as far as I can tell, is that, 6-year-olds will be 16, and someday they'll be 36, and someday they'll be 60. And just because our mandates don't necessarily allow us the flexibility to see people within a life journey, it's not the case that that life journey isn't true, right? So if you think about developmental periods that are very, very important in the ACEs conversation, well, 0 to 18 is where all those data, were collected, as we heard. But Dr. Clark talked about brain development in the ages of 0 to 5. There's another emerging developmental window that's really, really important between the ages of 8 and 12, kind of considered like an enrichment or in another sense, an equity window, whereby you begin to see performance differences in a range of measures between groups of young people who have higher socioeconomic status versus those who don't. So the idea that enrichment during that period seems to be driving an additional important developmental window in terms of brain health. Everything from food security to access to recreational opportunities to higher quality education. And when you think about communities where there is disadvantage, oftentimes it's in these kind of major areas where municipalities can also support to ensure that those kids who may not have within their families due to socioeconomic or otherwise reasons have access to those types of enriching experiences. That certainly that is an area where intervention can be very, very important. We also know prenatal health. We're learning more and more about prenatal effects. So, that 0 to 18, now we're 0 to 5, then we're 8 to 12, and now we're -2 to 0. And if we talk about brain development, that window actually stretches out to about the age of 25. So, when it comes to really trying to utilize ACEs as a framework for understanding conceptual models, understanding people as a function of their entire life journey, rather than discrete developmental windows and mandates is another way of organizing huge amounts of literature in a way that connects different pillars and different systems and different mandates in a more coherent way. It allows us as well to offer a broader spectrum of service. And one of the areas that we haven't heard a lot about today, but I'll mention briefly, is that I said earlier, a lot could be understood at the individual level as well. And, there's a lot to be understood from those individuals who have experienced ACEs, but who have also healed and who have also perhaps not ended up with the types of outcomes where that risk was elevated. Really trying to figure out what those essential factors are. Sometimes these have been described as, benevolent childhood experiences. So, having that caring adult who's got your best interests in mind and behaves as such, having access to community-based resources or housing or food programs or these types of things, your culture, really understanding so that we can build out the best comprehensive and spectrum of services that ensure that what we're doing is grounded to something. It's not that we're just kind of doing things in our own kind of way, but rather it's more of a comprehensive and organized conversation. And then really thinking as well in terms of how to help people understand what they can do to contribute to addressing, preventing, or mitigating ACEs, right? This is a question of empowerment. John talked about, our clients. I work at, I see patients at the organization that John works at. I've known John for a long time. And, in a study that we're doing with people in seeking addiction treatment services, our average number of ACEs in that group through our first look at the data was 5.4. That's the average number. I mean, I see people with as many as 9 and 10 out of that original ACEs list. So if we can utilize, so another thing that we do is we've developed psychoeducational courses or a program within the treatment center for people to understand what ACEs are, to understand the nature of how they seem to work and what the outcomes seem to be, but also as a means of empowering people with the information needed to be able to try and prevent those in their own homes or their communities once they leave treatment. And we've received a lot of good feedback from people who said, I didn't really, I always kind of knew this was the case, but I didn't have a way of describing it. I didn't really know what I could do about it. It always just sort of felt as though this was just the thing that I have to deal with. And I think if we can, come together in forums like this and, gather from a central place that's informed by the best of what we know from research evidence, from community perspectives, from culture, and utilize a framework like ACES as a means of organizing ourselves and having more in-depth conversations. And I think we're much more likely to do something that's really important and really good in our communities. So with that, I'll say, Jeannie Gwetch, thanks again for the opportunity to present here today with the panelists.
Thank you so much, Dr. Mushquash. Pleasure having you here with us today. I will just express my gratitude and my thanks to our panelists. Thank you also to Katie for keeping us on track and helping me through all of this technical difficulty I was experiencing today. I really appreciate all of you, the time you spent today. Thank you to everyone who tuned in and joined this session. I hope you find it useful and beneficial in the work that you do moving forward. The report itself, we're just figuring out how we are going to and where we are going to be posting the report. I know it will be posted on the national network, I believe, Katie. If we can send that out to our membership and anyone who's interested, we'd like to do that. I spoke with Rosemary Scoffitch from the Thunder Bay District Health Unit, who is involved in this project, and they will be posting it there as well. And we will post it on the City of Thunder Bay's website under the Community Safety and Wellbeing section. So it won't be done today, but very soon. And thanks again, Kim, for all of this great work and for sort of creating this opportunity for us to come together. So thanks so much, everyone.